invite Dr. Chamova from Sofia Medical University, Department of Neurology, from Bulgaria, where you will see their experiences and treatment strategies in SMA. Welcome. The floor is yours.
Thank you. I would like to thank the organizers for giving me the opportunity to talk about therapeutic strategies in spinal muscular atrophy, something that we're very proud to have now and to be able to offer to our patients, and to discuss a little bit on the situation we are currently having in Bulgaria with our SMA patients. As you all know, spinal muscular atrophy actually is a very big group of inherited disorders characterized by progressive muscle weakness and atrophy that is caused by the generation of the motor neurons located in the spinal cord and in the brainstem. Although the big majority of the patients have mutation in SMN1 gene, this is why we call them 5q SMA, there is a small proportion carrying other mutations and also known as non-5q SMAs. We're talking mainly about 5q SMA because this is where we currently have treatment to offer to our patients apart from the standards of care. And the prevalence of this 5q SMA is around 1 in 6,000 to 1 in 10,000 infants. The clinical phenotype in 5q SMA is confined to symmetric progressive proximal predominant limb weakness with subsequent involvement of the upper limbs after the axial muscles, intercostal, bulbar involvement. We all know that actually 5q SMA is a clinical continuum starting from non-sitters, passing through sitters and walkers, and this is related to the number of copies of SMN2. Of course, this copy number always straightforwardly correlated with the clinical severity, but in the majority of cases we see such correlation because of the development of these 3 treatments that we are now having as options. This classification is changing and will be changing in the future. Actually, it is very important to SMA timeline is very full in the last centuries. If we start with the first description of this disease in the end of 19th century, passing through the description by Kugelberg-Velander in 1956, but actually the discovery of SMN gene, that is the basis of these disorders, gave us the possibility for further therapeutic development. Of course, this therapeutic development that we are now seeing with these 3 medications is based on the previously developed standards of care, because we all know now that not only for SMA but for all the neuromuscular disorders, it is very important to have a multidisciplinary team that actually is working in developing the standards of care, and these teams are multidisciplinary, encompassing not only neurologists but pulmonologists, cardiologists, physiotherapists, and so on. In the last 10 years, because of clinical studies, now we can have these 3 therapies that we hope will be able to offer to our patients. Now we have 3 therapies approved by FDA, and 2 of them are approved by EMA, and for the last one, risdiplam, we are really waiting to see EMA's approval as well. The last standards of care that have been published for SMA actually are from 2018, and they're very detailed, stating what should be done in terms of diagnosis and follow-up. And they're really the basis for having the new therapies implemented in a successful manner. The therapeutic approaches we are now dealing with are trying to increase the SMN protein expression, because we know that SMN protein is crucial for survival of the motor neurons. This can be done in two ways, either by introducing the lacking or the deficient SMN protein by using viral vectors, something that has been tried in hemophilia, that is now currently tried to be done in patients with Duchenne muscular dystrophy. And the other way is by altering the SMN splicing process in order to be able to increase exon 7 inclusion, because we know that the main difference between SMN type 1 and SMN type 2 is this exon 7. This can be done either by antisense oligonucleotide that has been in a very detailed manner presented in the previous presentations, or by small molecules, but these two, they're targeting the splicing of SMA, SMN2 pre-mRNA. These are actually what we have as approaches. These are the already approved gene therapy by viral vectors and modification of the splicing, and what other therapeutic approaches in, of course, experimental stage. There are some approaches trying to reduce muscle atrophy by using myostatin inhibitors, or by using skeletal troponin activators. These are approaches that are not only tested in patients with SMA, but also in patients with other muscle dystrophies. So in terms of viral vector, we have this medication known as Zolgensma that is using viral vectors to be delivered. Actually, it is approved for the treatment of pediatric patients below the age of 2. And there is a recommendation of the dose according to the body weight. It is a viral infusion that is made once in a lifetime, and there are some intrathecal formulations that are currently undergoing development, but we'll see what will be their future results. In terms of splicing, we have antisense oligonucleotide, the first approved for SMA treatment, known as nusinersen. We know that actually it is delivered intrathecally. And we have 4 loading doses performed in the first 2 months, and afterwards, every 4 months, we have another dose. Of course, it's a potent treatment, but we can have some problems related mainly in patients with severe scoliosis, where CT scans are for performing this administration. And the last treatment that has been approved by FDA and now is actually we're hoping to be approved soon by EMA is risdiplam. It's an oral treatment, which of course makes our little patients that are undergoing intrathecal administrations very keen on having something to be given in an easier way and not requiring anesthesia. Risdiplam is a highly potent SMN2 splicing modifier, which increases exon 7 inclusion. And it is a powder that have different dosages according to the body weight and according to patient's age. What is the situation in Bulgaria? Bulgaria became member of Treat NMD, and this is why a year later we started to make our SMA registry. Currently we have 123 patients involved in the registry, and 4 years ago the clinic I work in, which is an expert center for hereditary neurologic and metabolic disorders, became a member of your NMD. Nusinersen started to be reimbursed in Bulgaria last year in May for all patients with 5q SMA, but actually it was due to financial reasons only given for those below the age of 18 years. We had 4 clinical centers that were approved for treating patients with nusinersen. They were located in 4 different university hospitals, dealing different with the different types of SMA. And in June 2019, the first application of nusinersen was performed. Currently, for the last year and a half, we have 30 children that are treated with nusinersen. And in the next year, we're trying to have this treatment available for a broader age range. So we're trying to discuss this with our health authorities to reimburse the treatment for patients over the age of 18. We had to start this year, but because of COVID pandemic, in the beginning of next year, we'll have compassionate use program for risdiplam in patients with SMA type 1 and type 2. And at the end, I would like to present a Bulgarian case, one of the cases by who we are trying to convince our health authorities that is very important to initiate treatment in adult patients with SMA as well. He is an adolescent boy who started having complaints at the age of 12, although he has never been very good at sports. He started having proximal muscle weakness, lower limbs, afterwards cramps in calf muscles and fasciculations a year later. At the age of 14, he started having muscle weakness in the proximal muscles of the upper limbs, and he was consulted in our clinic with EMG and genetic testing, and this is how he was diagnosed. He had homozygous deletion of SMN1 gene and 4 SMN. We started his treatment in June 2019, and if you all the patients that are having SMA type 3, they undergo regular every 4 months follow-up by 6 minutes walking test, by Hammersmith scale, by the module for the upper limbs, and ventilatory assessment. You see that in these patients we have an improvement that is observed and is more considerable after the 6 months of application. In terms of nusinersen and Hammersmith scale, he has an improvement as well. On this treatment, on the upper limb module, he is stable, but when we see him, he's gathering his suitcases when he come for infusion in our clinic, something that he could not do when he was diagnosed and before nusinersen treatment. These are his vital capacities. At 6 months, we have a slight decline, but actually this was a stage in the beginning of this year when he had a viral pneumonia. Maybe it was COVID, but it was before testing for COVID in Bulgaria, so we cannot know. Afterwards, of course, he improved very fast his vital capacities. And this is our patient. I don't yeah. Can we try to have them? Okay. So you see our patients who actually is performing his physiotherapy regularly, and he's coming back. He's becoming better and better, and he is making more and more exercises every single day. So he's very positive in this. And something that can we play the video that is important for him actually before nursing 2 years ago he stopped riding a bike because of the weakness and because he did not feel himself very stable, but now 2 years later after the 7th application of nusinersen, he's stable and he's continuing. So we see this boy, according to the natural history studies, there should be a decline, and on treatment we are not only seeing stabilization, but we are seeing a very big improvement in his motor abilities, something that is very important treatment for our patients. And with this, I would like you to thank you for your attention. I cannot hear you. I don't know if...
Yes, it's okay now. Sorry, I didn't mute. We have two questions, maybe will be more. The first question is, what do you think what kind of challenges do you see still for SMA treatment from patient or physician point of view?
Actually,
what kind of challenges?
There are different challenges in Bulgaria, which is not one of the richest countries. The challenges are, of course, economic, and there are some restrictions related now for the treatment of patients over 18 years. But we are trying to convince our health authorities to be able to administer the treatment, whatever it would be, nusinersen and hopefully risdiplam for all the